Good morning, good afternoon, good evening, wherever you are. My name is Bont. I'm the chairman of the ReSViNET Foundation, and it is my pleasure to welcome you here at our webinar series on RSV. Today, we have invited Professor Tina Hartert to present, but let me first share our vision and mission with you. Our vision is to connect global expertise and leadership in order to decrease the global burden of RSV infection, with the mission to support performance of high-quality research to improve knowledge of RSV epidemiology and to develop safe and effective therapeutic and preventive interventions. And we want to advocate and create awareness of RSV infection to act as a focal point for effective partnership with stakeholders and to combine knowledge and capacity required to enhance the development of novel RSV therapeutics. So why do we do this? This is a slide that you're all aware of, that you all know better than a lot of people in the world. 33 million patients, 3 million hospitalizations, 120,000 deaths, most of them occurring in the first months of life. A major burden of disease. In the next slide, you will see the objectives of the ReSViNET webinar series. We want to promote knowledge sharing of the latest developments and publications on groundbreaking studies and to provide education to professionals, including young professionals in the field of RSV. We do this every 2 to 3 months, and we look back on 12 webinar series so far. On average, we have 100 participants with high rating, with a very broad representation around the world, and a highly evaluated quality of interaction. And I'm sure we're going to see that again today. Since a year, we have started a new webinar series, or a twin webinar, in which Dr. Leakey explains the webinar by the presenter to the professional audience to the general public. And for the webinar of today, we will have the twin webinar for the general public on the 28th of September. So please share this with your friends and family and everybody who is belonging to the general public. Next slide. In November, we will have our next webinar, and we are currently finalizing the next speaker, which soon will be announced. Before we start the webinar of today, I want to shortly remind you that we will have the RSV Vaccines for the World meeting in February 13 to 16 in Mumbai, India. And I know that a lot of you are interested and will come and have actually already registered. And we have been able to grant about 60 applicants for full travel grants, which we are very proud of, with support of a lot of organizations, including the Bill and Melinda Gates Foundation. Next slide. Then now it's my pleasure to introduce Professor Tina Hartert. I hope you agree, Tina, that I call you a friend of mine over the past many years. We've been working together. We have shared young researchers. Tina is head of the Pediatric Pulmonology Department and the Center of Asthma Research at the Vanderbilt University in Tennessee. And today she will discuss the results of a recent publication in Lancet. I would like you all to ask your questions through the Q&A button at your screen. Don't use the chat preferably, and please switch off your camera, because then it allows us to see Tina in full. I will also switch off my camera I just want to remind you that we do encourage you to ask questions in the Q&A. Please use them because that facilitates the end of the session. Next slide. Enjoy the webinar. Tina, the floor is yours.
Thank you, Louis. Just pull up my slides. Can I just make sure that everyone is seeing the presenter view of my slides?
Yes, we do.
Okay,
perfect.
Terrific. Well, thank you. Well, Louis, thank you for the introduction and the invitation to speak here today. It really is an honor. So this may be a little different than some of the other RSV talks because my work and the work of our center actually focuses on the developmental origins of asthma. But one early life risk factor in which we're very interested is the role of early life RSV infection, and the relationship between RSV infection and asthma development is the focus of today's talk. So these are the questions that motivate our work on understanding the developmental origins of asthma and working towards asthma prevention. Is RSV infection during infancy associated with childhood asthma risk? And you're going to hear me talk a lot today about infection rather than severe infection. And if so, is there a critical time window and enhanced susceptibility to infection that confers a greater risk of asthma development? And through what pathways or mechanisms could RSV promote the development of chronic respiratory morbidity? But really, ultimately, what we want to know, and I hope at the end maybe we can have a conversation about this, is would preventing or delaying early life RSV infection prevent childhood asthma and respiratory morbidity? As this is an RSV group, I hope you'll bear with me for a few minutes because I want to emphasize a few things that I think are very important in thinking about environmental contributors to asthma development. And the first is to understand a little bit of a background about asthma and why we focus predominantly on childhood asthma, how I think about the concept of asthma prevention in terms of public health, and lastly, how we actually measure and have historically measured our outcome of asthma. So asthma was recently deemed by the World Health Organization to be one of the most significant non-communicable diseases globally. 358 million people worldwide have asthma, and the number of people with asthma has doubled since 1990, while the world's population during this time has gone from 5.5 to 7 billion. So this rise in incidence and prevalence over a relatively short period of time supports the role of environment in explaining this increase, as population genetics wouldn't account for such a rapid change. And that's the first important point. But asthma still contributes to many deaths worldwide. It imposes an unacceptable burden on our healthcare systems and on society. And we know that low-income and environmental injustice populations suffer disproportionate the higher asthma incidence and asthma morbidity. The next point is that asthma is also a highly heritable disease. And we know it's a complex genetic disease that results from gene by environment interactions, which probably explain variable susceptibility, meaning that the host genetic background and environmental factors drive disease development. And then lastly, the reason we focus on childhood asthma is because 80% of the onset of asthma is before age 8 years. So if we're going to prevent this disease, it's going to be through intervening during pregnancy and early childhood. The next point I want to make is how our group views asthma prevention. And you may be wondering why I'm showing you a cardiovascular disease slide, but I think this is a really nice analogy for how we think about asthma prevention. Because with cardiovascular disease, actually much like asthma, we know that there's a strong genetic susceptibility to disease development. We know there are these well-established modifiable risk factors that prevent disease, delay disease onset, or lessen disease severity if it does develop. And Finland provides one of my favorite examples of the community intervention, because in 1972, Finland actually had the world's highest cardiovascular disease mortality rate. And so planners examined policy and environmental factors contributing to cardiovascular disease mortality and implemented a series of public health interventions. And by 1992, cardiovascular disease mortality rates decreased among different age groups between 50 and over 90%. And what you'll see here is the greatest reductions were in younger individuals. So how is this analogous to asthma? So this is the slide I always say I hope I can show before I retire, or someone else on this webinar can show. And it's really a speculation about what I think the future holds for asthma prevention, because like cardiovascular disease, asthma is a complex hereditary disease. And even though I'm going to talk about RSV today, and it is one of the most important risk factors for asthma development, there isn't going to be a single modifiable factor that will prevent asthma. Multiple will lessen disease, and cumulatively on a population basis, this is what will have the greatest impact. So as the incidence of asthma is greatest in childhood, these interventions similarly, they're going to need to be during pregnancy and infancy, and this is where we're likely to see the greatest reductions in asthma development. So the third thing that I want you to know about asthma is that asthma is actually a syndrome. It's really an umbrella diagnosis for several diseases with distinct mechanistic pathways, or what we call endotypes, and variable clinical presentations or phenotypes. And our current approach to both clinical care and most all research studies with the outcome of asthma is analogous to the pathogenesis and management of arthritis as one disease, thinking that something like osteoarthritis or rheumatoid arthritis would be the same. And this is really actually particularly important in childhood asthma, because we apply treatments in childhood asthma largely universally to all children with asthma, even though there's some fairly good evidence that the treatments we use may not benefit certain phenotypes. And if we do the same with understanding environmental contributors to asthma development, we will make the same mistake and probably also dilute the effect of these environmental contributors to certain asthma phenotypes. So to make significant progress in understanding environmental origins of disease, it's important for us to understand specific asthma phenotypes. And this is a number of problems in all prior studies of RSV and asthma. So as I mentioned, I know this group needs no introduction to RSV, so I'm not going to actually tell you anything about RSV. People on this seminar could probably teach me much more about it. But before we move into understanding studies of RSV and asthma association, I'm going to share just one summary slide to explain why, among what I just shared with you, is that a multitude of asthma risk factors, this is a really important asthma risk factor. So this is data from hundreds of studies to provide summary estimates of exposure prevalence, and where we used odds ratios from meta-analyses to calculate population attributable fraction for each risk or protective factor. So the risk factors here are above this dotted line, and the protective factors are below the dashed line. And the points of the graph reflect the relationship of exposure prevalence on the x-axis and the calculated population attributable fraction on the y-axis. And these data demonstrate really the three major reasons why we focus on RSV and its association with asthma. First, it's prevalent. It's a common exposure in early childhood. If causal, it has a high population attributable fraction. And then lastly, we know it's potentially modifiable. So with this as background, now let's turn to the association between RSV and asthma. So this association between the clinical entity of bronchiolitis or severe RSV infection and later childhood asthma was actually first demonstrated just shortly after the discovery of RSV infection in the late 1950s, although at the time there weren't readily available means to identify the virus in clinical care. So this was a group of 100 hospitalized infants, of whom 32% went on to develop what was termed bronchial asthma, and another 17%, importantly, had other long-term respiratory morbidity. And what's resulted is nearly every study for the past 60 years that's looked at the association between RSV and asthma have focused on severe RSV infection. And a large majority of these have focused on infants hospitalized for RSV, which we all know represents only about 1 to 3% of infants, at least in high-income countries. So we've been left with this decade-old debate about whether respiratory viruses such as RSV cause asthma. Is the association that we see just the result of a shared genetic predisposition for both conditions, or is there a contribution of both? And I'm going to explain why this is a problem and how we can tackle this problem. So to understand the contribution of heredity to severe infection with RSV, in this study we applied meta-analytic techniques to assess causal relationships in this huge number of prior studies of RSV lower respiratory tract infection and asthma. And if you look at this plot, the study summarized on the bottom in black, in which there are no adjustments for heredity, which we compare with the studies summarized in red, in which there is some adjustment for heredity or family history. You can see that estimates of effect sizes are on average smaller across the studies when we adjust for a marker of genetic confounding. And then lastly, in blue is one very small study of monozygotic twins, 37, that provides an even smaller effect estimate of RSV lower respiratory tract infection and asthma, although admittedly there's enormous confidence intervals. But these findings are consistent with severity of RSV infection being at least partly a marker of shared genetic susceptibility with asthma, rather than a purely causal exposure. So to illustrate the challenges and approaches to studying only severe RSV infection and its association with asthma, this cartoon depicts a gene environment model of severe RSV infection and asthma. So the top blue circle represents all genes or genetic variants that are associated with severity of response to RSV. And then the red circle on the bottom represents all genes or genetic variants associated with asthma. And the overlap represents the subset of genes or variants that contribute to both severe RSV infection and asthma. And while we've had a plethora of asthma GWAS studies, the same is not true for RSV infection severity. They're much harder to conduct. And thus, the lack of GWAS studies for severe respiratory viral infection means that many SNPs, in fact, the large majority studied extensively in asthma, haven't been examined in studies of severe RSV infection. And thus, the problem is that we don't know if this shared genetic susceptibility to both diseases explains a small part of this association, as in the last slide, or nearly all of the association between severity of RSV infection with asthma risk, as on this slide. And the second is that these children who develop severe RSV infection likely represent those who are at highest risk of developing asthma, and actually may be those in whom we are least likely actually to prevent development of disease. And this is important in considering looking at or using RSV prevention products even for proof of concept in assessing only the prevention of the most severe RSV infections and demonstrating the link between RSV and asthma. So as we had demonstrated the shared heritability to both severe RSV infection and asthma, we asked a question of whether there might be a genetic susceptibility to just being infected with RSV. I know that doesn't seem likely since all children are infected by about age 2. We did this to determine if there would be any residual or significant genetic confounding with the approach of studying all RSV infections as a true exposure rather than studying an association with a clinical phenotype of RSV. So in a GWAS analysis, there were no significant associations of any SNP with infant RSV infection among those of European ancestry or African ancestry when we had adjusted for multiple covariates. But while RSV GWAS revealed no genome-wide significant associations between genotype and RSV, we recognize in a study of just under 2,000 infants that it's still possible that the multiple testing burden precludes our ability to identify an accumulation of small genetic effects. So here what we did is we also estimated the narrow sense heritability of RSV infection, which if greater than 0, indicates that there's likely an accumulation of small genetic effects accounting for the association. But the maximum likelihood estimate equaled 0, supporting no likely genetic risk for RSV infection. And then lastly, on the right, we did a candidate gene analysis of the most likely genes for asthma and severe RSV risk, and also found no associations. So we believe that at least in this small and limited study, that there's no evidence of a significant host genetic predisposition to become infected with RSV that would result in significant genetic confounding using an approach of RSV infection as an exposure. So let me just summarize then the problems of prior approaches and how we can tackle this as a field. So despite more than 60 years of research that have examined the relationship between severe RSV infection and asthma, misclassification of both the exposure using only severe infection and the outcome have impeded our progress, I think, in establishing whether there's a causal association and, importantly, advancing asthma prevention efforts. So RSV bronchiolitis, as I've mentioned, it's a clinical phenotype. It's not an exposure. And it's also an RSV phenotype that has a clinical presentation similar to that of asthma. And I've shown you there's evidence of shared heredity between these two conditions. The second is that the outcome of asthma also continues to be this poorly defined syndrome, and that environmental contributors to different asthma phenotypes are really important to understand. We have a very large ongoing study with almost 10,000 children to look at the variable contributions of environmental risk factors on asthma phenotype development. So these limitations in ascertainment of the exposure and outcome are really what have informed our causal inference studies. So to address these limitations, we began by conducting studies of birth timing in relationship to RSV circulation, using birth timing as a random event. And we asked what was really a very simple question, and that is timing of infant birth in relationship to RSV circulation associated with risk for childhood asthma. We studied over 95,000 infants, and importantly, we studied 6 RSV seasons, where the variability in the start and the peak and the end of these 6 seasons varied by almost 2 months. And the risk of asthma was associated with birth timing in relationship to RSV circulation. And infants who are on average 4 months of age at the peak of RSV season in any given year were at the highest risk of developing asthma, about a 30% increased risk. And this association between infant birth in relation to annual and variable RSV circulation and subsequent asthma is difficult to explain through non-causal mechanisms. This relationship was significant for all 6 years of study, and in any given winter virus season, the peak asthma risk was within 1 day of the RSV peak in each of these years. So we didn't stop there. Because we couldn't identify RSV infection in those populations, we were using birth timing as an instrumental variable. So in a prospective study, which we designed because genes, we understand, are a confounder or a mediator, what we know is randomization obviously would allow us to distinguish between these situations, but it's obviously unethical to randomize infants to be infected with respiratory viruses such as RSV. So what we designed is a natural quasi-randomization study, the INSPIRE study, of nearly 2,000 healthy term normal birth weight infants to precisely measure infection with RSV in the first year of life using combined biweekly surveillance during RSV season and RSV serology at 1 year in this population-based birth cohort, measuring the known risk factors for RSV infection, which are largely exposure, like siblings and daycare, etc. So in this cohort, approximately 50% of infants, shown here in the red, were infected with RSV in the first year of life, and the other half, in pink in this inner donut, were uninfected. We detected about 40% of RSV infections through biweekly surveillance, which we show here in the blue, and about 60% were picked up through serology. However, it's important to recognize that this symptomatic group is probably an underrepresentation, as we didn't have 100% capture of biweekly surveys and visits. But among this group with symptomatic infection, 17% had lower respiratory tract infection, and the remainder had upper respiratory tract infection. 1.4% of the total cohort required hospitalization. And in the INSPIRE study, and the slides I'm going to show you next, we compared those in red, infected during infancy by capturing all infections with surveillance and serology, to those in pink who were uninfected in infancy. So having defined every infant as infected or not infected with RSV in the first year of life, what we wanted to understand is the impact of delayed infection in infancy. So infants who weren't infected with RSV in the first year of life had a reduced risk of recurrent wheeze at ages 2, 3, and 4 years, and a 26% reduced risk of 5-year asthma, demonstrating an age-dependent relationship between RSV infection and asthma risk. And we estimated the population attributable fraction, or the fraction of asthma that could be prevented if we delay RSV infection if it's causal, at 15%. So to assess the severity of RSV infection among infants who had the in-person visits picked up by symptomatic infection, we used a respiratory severity score. And this is an ordinal scale that ranges from 0 to 12, which is on the x-axis here, with the higher values indicating more severe disease. And there was a positive association between the severity of RSV infection in this model during infancy, as measured by the respiratory severity scale, and the risk of 5-year current asthma on the y-axis, despite the fact that there was actually very little severe RSV infection in this cohort. So while this study was powered on asthma's outcome, and we weren't powered for asthma phenotypes, this is a post hoc analysis of asthma subtypes, which illustrates the importance of studying not just the umbrella term of asthma, but asthma subtypes. And as I mentioned, we have a much larger study looking at the environmental contributors to asthma phenotypes. So similar to other cohorts, that have assessed atopic and non-atopic asthma phenotypes in the last several decades, just slightly more than half of the children with asthma had atopian asthma or atopic asthma, 53%, while 47% of asthma without atopy or non-atopic asthma. An RSV infection is a risk factor predominantly for non-atopic asthma, nearly halving the risk, and has a much smaller and non-significant impact on atopic asthma phenotype, meaning that delay of infant infection may protect most strongly against one subtype of asthma, non-atopic asthma. And we see this also for other environmental risk factors. So if RSV causes asthma, then through what mechanisms or pathways? And this is a summary and figurative representation of our hypotheses and studies from our group of the impact of RSV on the early life airway. And this doesn't acknowledge that there's been a tremendous amount of work from others in the field in animal and cell models that I won't even cover in this simple pictorial diagram, that also provide very important additional biologic mechanisms that explain how RSV may contribute to long-term respiratory morbidity. So the first is a very interesting and challenging aspect of studying viruses as an environmental risk factor, is that viruses, actually like the host, also have genetic variability that may influence disease outcomes. And things like pollution don't have genetic variability. So we've identified variants that are actually associated with variable infection severity and persistence of infection. And we speculate that viruses that either could evade immune detection or have a capacity for persistence could potentially promote development of changes of the early life airway epithelium. And then we and others have also shown that the early life RSV infection is associated with a marked change in the airway microbiome. And this change is characterized by an increase in Streptococcus, Moraxella, and Haemophilus, which you'll recognize as pneumonia pathogens, and why we believe we see increased risk of pneumonia, not only short-term, but actually long-term following RSV infection. We also see a decrease in Lactobacillus, which we think is a protective genus. And this is a pattern of the microbiome that's been repeatedly demonstrated to be associated with increased asthma risk. So early life RSV infection is also associated with epithelial metabolic reprogramming, evidence of barrier disruption, as well as dampening of antiviral memory T cell responses. And these changes, we think, may predispose the children to allergic sensitization because the epithelial barrier is disrupted. The mucus gland production is different in these airways, and to enhance susceptibility to irritants such as pollution and repeated respiratory viral infections that characterize early childhood asthma. And then lastly, our current studies focus on the impact of RSV infection on cell-specific airway epithelial epigenetic changes and using single-cell RNA-seq of the airway to understand how RSV influences airway epithelial development. So to summarize, well, I know for many in this group, the study of severe RSV infection is critically important, and there's no doubt. But for asthma, studying RSV infection as exposure is what will really be more informative for studies of causal inference. So taking this approach, I hope I've convinced you that in large-scale population-based birth cohort studies of healthy term infants, we've demonstrated that birth timing in relationship to RSV circulation is associated with asthma risk, and that delayed RSV infection until after the first year of life is associated with a substantially reduced risk of developing childhood asthma, and that these findings support a causal, age-dependent relationship between RSV infection in infancy and pediatric wheezing phenotypes and asthma. And furthermore, they suggest that delaying the initial RSV infection could be a strategy to decrease the prevalence of childhood asthma. And this really fundamentally changes how we've thought about the preventive potential of the relationship of RSV infection and childhood asthma away from severe infection and to RSV infection. And I think we all recognize on this call that the dramatic global reduction in the incidence of RSV infection that resulted from relatively simple public health measures to limit the transmission of SARS-CoV-2 demonstrates actually that potentially simple non-pharmaceutical interventions during an age-dependent period when RSV has the greatest impact on childhood asthma could be studied to determine if delaying initial RSV infection could decrease asthma risk. And then I want to end by putting into context and hopefully starting a discussion in our discussion period of why this is important and where we go next. So while multiple recent lines of evidence that I've shown you support a causal role of RSV infection during infancy and the development of asthma in childhood, observational studies never definitively establish causality. However, these findings really change the concept that this virus is just an in and out and only contributes to acute illness. And it's also important to recognize that this isn't about prevention of RSV lower respiratory tract infection to reduce wheeze or asthma, as these are probably the children likely destined to develop asthma and may be most refractory actually to preventive interventions. Rather, it's about delaying first RSV infection among children or among infants. So we have this time-sensitive opportunity to actually capitalize on large consortiums of carefully harmonized birth cohorts, doing longitudinal follow-up of ongoing randomized trials of prevention products, using novel study designs, capitalizing on a pandemic period, or applying improved statistical methods to better endotype and phenotype children to study our outcome, and to study these novel RSV preventive strategies to make progress actually in understanding whether delaying initial RSV infection during infancy decreases asthma and other long-term respiratory morbidity. Because demonstrating impact on delay of initial infection on long-term respiratory morbidity actually has significant implications for added value, not only for decreasing acute infant morbidity, but also long-term early respiratory morbidity. And this is what will ultimately allow us to design effective primary prevention strategies for asthma and improve child respiratory health. So I'll conclude by acknowledging the incredibly talented team investigators with whom I daily have the privilege of working and whose individual work I acknowledged in each of the data slides. So thank you. I welcome our discussion and I'm happy to take questions.
Thank you, Tina. That was incredible. And you explained it so well, how it is important to not just study severe disease, but also just study any infection to understand the relationship between RSV and asthma. So it's my privilege to translate the questions for you. So one of the questions that I'm sure you actually hinted to that in your presentation towards the end is, what do you expect from people, babies born during the COVID pandemic, during the time that we had zero transmission? And maybe you can also speculate what that means for those children born in summer when we had a delayed summer RSV epidemic, which is unusual, or maybe the first time ever. Just give us your prediction and how are we going to study that?
Yeah, I always get asked this question. And it seems like this, when you first glance at it, at first glance, it seems like this ideal natural, a natural event to study. And I do think it's of value studying, because as you mentioned, we have two really interesting things that have happened. We had no RSV infection, and then we had a summer peak. But there's a tremendous amount of confounding that's going to be really hard to measure in all of these studies, right? Because it's not the only thing that changed during the pandemic. That's a risk factor for asthma development. So children may have been in homes where there were more or less stress. They weren't in school. They could have been around parents who were smoking more. There was less pollution in general across the world. So while it seems like an ideal thing to study, I think ultimately measuring the confounders will be extremely challenging. But I do think taking many years of infection and then also using the summer peak may provide some important evidence, just realizing the major limitations.
Thank you. Thank you for your careful answer. I thought if you're born during this time of no transmission, maybe you're a little bit better off than when you're born during the peak of transmission, but actually we don't know. There are so many other factors that are very difficult to predict the net effect. So thank you. Let me just repeat to the audience, feel free to ask your questions in the Q&A and not in the chat. We have two questions related to understand RSV infection and the development of recurrent wheeze and asthma. One is about the timing. Does it matter at what age RSV happens? And the other one is, does it matter how many RSV infections occur to understand asthma development? Tina. Yeah,
that's a great questions and something I'm sure a number of us are really interested in. So, our study with just fewer than 2,000 infants wasn't adequately powered with any granularity to assess age effect. We assessed age effect of infection in the first year compared to infection after the first year of life. This is absolutely something that needs to be done. We're utilizing an ECHO consortium in the US, which are a group of harmonized birth cohorts to try to get at this question, but it's going to take a much larger sample size than 2,000 infants to get more granular than first year compared to after the first year of life. There are some studies of age of severe RSV infection and asthma development. And actually, one of our Fulbright fellows is working on a meta-analysis actually of these studies. I think the problem of those studies is it's looking again at severe RSV infection rather than RSV infection and asthma development. And what we really need to look at is age of RSV infection rather than severe infection. And then I'm not going to remember, what was the last part of the question?
No, I think you addressed the timing and the number of infections in relation to
yes. Sorry, I didn't answer that part. So in the first year of life, in our study, there were only 19 infants who had more than one RSV infection out of nearly 2,000 infants. So I think repeat infections happen. I don't think they're terribly common, and our study certainly wasn't powered to address the impact of repeated infections. But I think it's a really interesting question, because I do believe in sort of the multiple hit hypothesis of contributing to asthma development.
So Marta Nunez is asking whether you looked at other viruses than RSV.
Yes, so we did look at rhinovirus as well. The reason that RSV is a really nice model to study, unlike rhinovirus, is that 100% of children are infected with rhinovirus in the first year of life, and usually multiple times. Whereas RSV is a really nice model from an epidemiologic perspective, because as you saw, about half are infected and about half are not infected. My personal view of rhinovirus infection, if you look at the studies that look at rhinovirus over time, is that wheezing with rhinovirus, like wheezing with RSV, is a marker of risk for developing asthma. And there are clearly things that are different about these two viruses. The age at which you have lower respiratory tract infection with these two viruses is vastly different. With RSV, the risk of having lower respiratory tract infection decreases with time. With rhinovirus, it's exactly the opposite. And so I think these viruses are different. If you look at the impact these two viruses have on the developing microbiome, they're also very different. So I do think, like I said earlier, I believe in this sort of multiple hit hypothesis, and I think RSV actually likely may predispose infants actually to potentially repeated more severe infections.
So can you remind us, Laura Hamid asked us how asthma was ascertained and what you think of peak flows and other lung function measurements.
Yeah, so asthma was ascertained in this study by a report of physician diagnosis, and we also required symptoms in the last 12 months and asthma-specific therapies, which I know is maybe more criteria than many other studies may have used, which is maybe just a parent report of asthma. But we also looked at the individual contributors to asthma and using multiple different asthma diagnoses, and we found the same results.
Thank you. Abdullah Mamoun is asking about the use of antibiotics. Do you have that information, and was it related to either RSV infection outcome or anything else? And do you have any information on microbiome outcomes in your study, either respiratory or from the gut? A little bit on bacteria in this meeting, Tina.
Yeah. Yeah, so we think, I think, as I alluded to very briefly, because I know in this short talk, I could spend a whole time talking about microbiome, and we have several investigators who are really interested in this in our group. So yes, we looked at antibiotics and we captured antibiotic utilization, and we're actually looking at how antibiotics alter the development of the microbiome. We adjusted for antibiotic utilization in this study because I think that's very important. Antibiotics have been shown to be associated with asthma development previously. And we have a funded major microbiome focus actually as part of the INSPIRE study, where we're looking at both the airway microbiome as well as the gut microbiome and the airway gut access. And we think this is very important. And we think one of the things that RSV does when you have early RSV infection is it alters the airway microbiome, promoting what are bacterial pathogens, which is why we think we see actually increased otitis media and pneumonia actually following RSV infections, but it also decreases our protective bacteria like lactobacillus. And there's a very interesting animal model actually that gave nasal lactobacillus and then infected with RSV and showed the protective effect actually of lactobacillus in the nose on establishing or severity of RSV infection.
Thank you. So Pete Dayananda is giving a very difficult question. Do you think that RSV-associated childhood asthma persists into adulthood in your study? I know that these children are not yet old enough to be adults, but I do think it's an intriguing question whether you feel that this is something for life.
Yeah, so it's a really interesting question. You're right, I can't answer, I can only speculate about this and tell you the little bit of evidence that is out there. So there are some long-term follow-up studies of severe RSV infection, RSV lower respiratory tract infection, with all the caveats we talked about in the last 30 minutes, that do support continued risk into adulthood. Now, the important thing to remember is that asthma is an episodic disease, and people have periods of remission, but there is a small amount of data to suggest there's a persistence. There was also a recent Lancet article, actually, and again, it looked at severe RSV lower respiratory tract infection, but that shows that there's increased respiratory mortality, actually, in adults who had severe infection during childhood.
So let's talk about vaccines. This is the first time in many years that we were able to hold off discussing vaccines for more than 45 minutes, but there we are. What about vaccines? So there is also a good number of participants working at the development of vaccines. How do these vaccine developers study RSV and asthma? How should they do that? What are the opportunities? Is it possible to do a full asthma assessment at school age, which is a long interval? Please tell us what you think about what the world should do about understanding the potential of RSV interventions at the moment.
Yeah. So I do think we have this amazing opportunity because we'll never have it again, right? We have ongoing randomized clinical trials of RSV prevention products. And I think we do have the opportunity to do, obviously, unblinded, long-term follow-up for asthma, but I would argue we should do all respiratory morbidity, not just asthma. I think recurrent wheezing, otitis media, antibiotic utilization, pneumonia, not just asthma if we do longitudinal follow-up. I do think this longitudinal follow-up can be done relatively simply we have pretty good survey techniques actually for asthma. Having said that, I also want to mention a few cautions. These RSV prevention products probably don't prevent infection. And I've talked largely about infection or delay of infection as really the important risk factor. However, on a large scale, I showed you that there is a severity-dependent effect even in mild infection across the whole spectrum of severity. So on a large scale, if these RSV prevention products decrease severity of all infection, there could potentially be a protective effect. But as I mentioned, I think it really is important for us to understand that while these are randomized clinical trials, we shouldn't think about these trials as randomizing to RSV infection, no infection. Right? Because there's no evidence that these RSV prevention products actually prevent infection.
Right. So even if they prevent severe infection, they may not prevent any infection, and therefore their impact on asthma development is unpredictable at the moment. Are you aware that any of these companies, there are a lot of them making RSV vaccines, is Jefferson Jones from CDC asking, actually do study asthma development to the best of your knowledge? What is actually being done at the moment?
You know, I don't know. I've been asked about this, and I think that there's some level of interest. I do think, we've collaborated with others who've actually published some sample size estimates of how large these trials would likely be, and it probably will take collaborating across some of these companies with harmonized survey instruments, probably to be adequately powered to answer this question, but I'm not aware of an actual ongoing effort.
So with your own study, if the impact or the effect size that you see from RSV infection would actually be translated to prevention of vaccines, what would the sample size be to demonstrate an effect? Were you able to recalculate the sample size based on your current data? Because maybe they are not as large as we thought at the time we wrote that paper, Tina.
Yeah, it's a good question, but the range of sample sizes actually projected a range of effect estimates. So it still does look as if it probably would take, combining several of these randomized controlled trials across companies with standardized collection instruments, which I don't think is a hard thing to do, because I do think a lot of these outcomes can be measured with just survey instruments.
Thank you. Before we close this webinar, there is one more question, if there are no others. There is a burning question from Evangeline Obodai about the association between severity and the development of asthma. Why is that? It is quite intuitive to think that if you're not severely ill, you're not going to develop asthma. So can you give us some pathophysiological thoughts? You speculated it during your presentation, but give us a little bit more of your thoughts, why this is.
Yeah, well, severity in part, at least at the severe end of the spectrum, is probably largely defined by shared heredity. So I think these are going to be the children who are probably going to be most refractory to preventing disease. This could be the case across the entire spectrum of disease, but as I said, we had very, very little severe disease. So the first comment that I'd make is it's not unusual for viruses that result in chronic diseases to not necessarily cause the most severe acute disease. So, not that RSV is anything like human papillomavirus or HIV or Hep B, but when we do look at viruses that contribute to longer-term morbidity, it's not always the virus that causes the most severe disease, actually. So that would be the first thing. Even though I completely agree with you, it seems to make sense intuitively that a virus that does the most acute injury would have the greatest long-term effect. But I think we have to balance that with what we actually know about the potential that a virus has for causing chronic changes. And in fact, it may be viruses that induce the least acute immune response, so that actually a virus can't be cleared effectively, and that actually could potentially contribute to greater long-term changes in the developing of the airway epithelium. And really the airway, this is an airway disease. It's not really a systemic disease, and that is the organ that's infected and affected in this disease.
Thank you so much again. With this, we come to the end of the webinar. I would like everybody to stay to fill out the questionnaire to evaluate this webinar. It's anonymous. It's very important to the foundation. I hope you enjoyed it as much as I did. It's going to be available online through our ReSViNET website. Please share it with all the people that were not able to come here and enjoyed it. Please remember that we will also translate this webinar for the general public. With that, I would like to thank you, Tina, again for a wonderful, wonderful, wonderful webinar. I enjoyed it a lot, and I'm sure others did too. I hope to see you all soon. Bye.
Thank you.